Bienvenue, j'espère que vous avez bien.
Welcome back. I hope you enjoyed lunch.
Lovely that you're well fed. You've had lots of stimulation this morning. This afternoon, we have an equally exciting program for you. And we're going to start it off again. Just a reminder that we've got 2 or 3 sessions that will be in French exclusively this afternoon, starting with our next speaker. This is something we call Pro Talks. If those of you who have been at partnership conferences before, you know it's sort of a quick 10-15 minutes on a topic that's high interest. And so I'm really pleased to introduce our first Pro Talk speaker, Waldo Beauséjour. Waldo is an analyst with our performance analytics team at Canada Health Infoway. And so he leads a lot of our work on equity. And I know that came up at a topic this morning, so I'm really pleased about that. So Waldo is going to talk to us about digital health equity in Canada. What do the numbers tell us? Bienvenue. Merci, Waldo.
Welcome and thank you, Waldo. Good afternoon, everyone. I'd like to start by welcoming you to Montreal. My name is Beauséjour, which means have a nice stay in French. This is my second face-to-face conference in Montreal in the post-pandemic period. And I'm not even sure we can talk about a post-pandemic period because the pandemic isn't finished. But the COVID-19 pandemic forced us to take drastic decisions professionally and personally. Personally, one of those decisions for me was the smart one to take, but I decided to purchase this small device, an infrared contactless thermometer. I hope you have one at home. The idea was simple, to follow the evolution of my family's temperature, measuring their temperature. And measuring is an important aspect of our work. Health indicators are examples of measurements that are ubiquitous in our everyday lives. For example, with indicators, we can understand the increase of healthcare services throughout the pandemic. A survey showed us that we went from a 10 to 20% adoption rate. That's the proportion of Canadians who access virtual healthcare. We went from a 10 to 20% proportion in 2019, before the pandemic, to a 60% plus adoption rate early in the pandemic in April 2020. And this adoption rate stabilized or plateaued around 30% early 2022. On the offer side, the Canadian Health Institute showed us that 45% of physicians provided at least one type of virtual care in February 2020, compared to 83% in September of that same year. The uptake of virtual care on the professional and patient side allowed Canadians to access healthcare safely throughout the pandemic. This may have limited infection rates and the spread of coronavirus. But this dramatic uptake of virtual care didn't reduce inequalities in the area of digital health. This increase of digital health benefited a certain percentage of the population, and the question is who benefited from it. What do the figures or the numbers tell us? Remember that Canada is a pioneer in the development of virtual care. You may remember the work of the deceased Dr. Maxwell House's work with proximity models to correct certain inequalities and to service populations in remote regions. We also realized that paradoxically, as some surveys showed us, digital health may perpetrate and even amplify certain inequalities, which is why digital healthcare equity is so complex. To understand it a little bit more, let's peel away the onion skin of the healthcare system. The first layer is related to social demographic factors, place of residence, socioeconomic factors, income, employment, digital literacy, knowledge, skills, the capacity to use digital health technologies for decision making and health management. On the second layer, you have health factors that are directly related to health. Access to a physician, access to Medicare. And for the first layer, we often talk about social determinants of health. And within the Special Working Group's report on health equity, there are two additional layers, structural determinants, governance, policy, regulations, and digital determinants, connectivity, interoperability, and broadband internet. When it comes to digital health care, it isn't only about video and video conference. The framework goes beyond those two technologies and include e-prescribing, e-booking, secure messaging, video conference, remote monitoring, and e-mental health. This is a mosaic of digital healthcare. And to generate data on access and the use of these technologies, we looked into the Canadian Survey on Digital Health. It's an annual survey that collects data on attitudes, access, perceptions, with an online survey that is sent to over 12,000 Canadians in Canadian jurisdictions. From this data, we tried to identify different groups of users in the field of digital health. We conducted a cluster analysis. The idea was to identify subsets of users. From this analysis, we identified two major groups of digital health users. On the one hand, a group that is not very interested in digital health and a lower use of digital health services, 22%, and on the other side, stronger adopters of virtual health and higher interest for digital health services. The rate of usage in the second group is close to 30%. To understand the difference between two groups, we looked at the different social and demographic factors. On the one hand, you have a group of older users, mostly women, females with lower income, from smaller communities, less highly educated, and with a lower digital health literacy. That may be a reason that explains the lower adoption rate of digital health. On the other hand, you have a group of younger people with a more even gender distribution in terms of gender, higher income, from larger communities that are more highly educated and with a higher digital health literacy. This cluster analysis gave us the opportunity to lay down the foundations of our inquiry into the inequalities of digital health. The first step was to measure inequalities themselves, to understand where they come from, and we thus used different proportions, ratios to measure inequalities and understand where they came from. First of all, we looked at factors influencing healthcare, starting with access to digital health services, access to a physician. Those who had a family physician were twice as likely to access digital health compared to those who didn't. You probably agree that unattached patients don't have the same continuity of care. They get less preventive care and have more chances to go to the emergency. From a chronic illness perspective, we noticed that those with a chronic illness were more likely to access digital care, which represented 56% compared to 44% of those without a chronic illness. For health insurance coverage, those who did have a public or private insurance were more likely to access digital health compared to those who didn't have any coverage. And for the last group, the access rate was close to 35%. For the social demographic factors, first of all, the age of people, we identified two major groups of users. On the one hand, the millennials between 25 and 39 years, and older adults, 65 plus. This was throughout the pandemic. And for those two groups, the access rates were close to 59% and 53% or 51% respectively. For the geographic location, we also noticed that people from urban centers were more likely to access digital health with 51% and used digital health services more often than those from rural and remote regions. And remember, the main objective of virtual care was to service populations from remote and rural regions. For the race and ethnicity category, we noted that Black and Indigenous peoples who are generally part of marginalized and racialized communities were less likely to access digital health services, with 44% and 47% respectively. For the primary language spoken at home, we noted that those who spoke another language beyond French or English were less likely to access digital health services, with 46%. Household income, we measured the household income, which is an indicator that showed us that the proportion of Canadians who access digital health services increased with the level of household income. The higher it was, the more likely they were to access digital health services. Everybody here in this audience share one commonality. We're privileged. Some of us have access to a family physician, healthcare coverage, knowledge, skills, and we know how to access digital health services. Unfortunately, some Canadians don't have that privilege, which creates inequalities. Digital health may correct those inequalities because it facilitates access to care. Now, what can we do? First of all, the provision of virtual health care services must take into account the social determinants of health. As the statistics I showed you demonstrated, if you want to measure the performance of a digital health project, you have to start collecting data to measure all of these outcomes. Thank you.
Merci beaucoup, Waldo. All of us that we need to measure, and we need to, if we're going to make a difference, we need to make a difference for everyone. So thank you very much.